It's such a pleasure for me to be here this afternoon with you, Yoel, and to see so many of my, and to hear so many of my colleagues and friends who've contributed to this. And I'm delighted and honored to be part of this afternoon. My response is to one of my old colleagues, Dr. Cynthia Gyamfi. Delighted to see her in her new role in San Diego. And I thought in thinking about this, I would look back to where we were. We can just advance this. Okay, thank you. Where I had a call to action in 2010, because my focus until that time had been on ultrasound detection of abnormalities. And I saw the growing maternal risk in our specialty, and I did not feel there was enough attention to the risk that we were seeing as women around us. We were seeing increasing incidence of obesity, diabetes, and I didn't feel there was enough focus. And I sort of wrote a call to action, if you will, and felt that we need to develop an organized national approach to reduce maternal morbidity and mortality. And the goal was to have a specific clinical plan, educational and research plan to put the M back into MFM. And of course, this was a play on the words of Dr. Alan Rosenfield and Deborah Main that had published Where is the M in Maternal Child Health, that was published in The Lancet in 1985, now so many years ago. So in 2012, a number of us got together, 22 of us got together representing 4 different organizations: the Society of MFM, the American Board of OBGYN, ACOG, and the NICHD, to evaluate these 3 areas and come up with a plan. And then in 2018, we came back and reviewed where we were based on our recommendations. And I'd like to share that with you today. The next slide. Okay. We identified 7 critical research gaps in maternal health in 2013. And we find, looking back in 2018, that we had made some modest progress. First of all, let me address the first gap: to develop national standardized methods for national surveillance of maternal mortality and morbidity. The CDC Pregnancy Mortality Surveillance System had been tracking maternal deaths since 1986. This relied on death certificates for women thought to have died during or within 1 year of pregnancy. Of course, using vital records, under ascertainment and false positive concerns are very valid. And so it was very important to think about standardized clinical review that could be done across the country. In 2012, there was 18 states and 1 city that had maternal mortality reviews. Whereas when we came together in 2018, 36 states had maternal mortality reviews. And today, 47 states have maternal mortality reviews in 3 cities. Very importantly, the Prevention of Maternal Deaths Act, a bill that was signed into law in December in 2018, authorizes the CDC to provide assistance to states setting up maternal mortality review boards and ensuring standardized review and data collection processes. This has not only led to greater number of committees, but has enhanced the quality of the review, and I think is a very, very big step forward. And for those of you who have worked with the CDC, they have been absolutely phenomenal in this area, and I think represents very significant improvement in our reviews of maternal death, that some of which were presented in the previous slides this morning. And of course, the ultimate goal, of course, is that there is a standardized high quality review done on every maternal death in our country. But with that, there's a significant gap in reviewing maternal morbidity. And we've got to move on, not just to review maternal death, but to review maternal morbidity. And that is extremely time consuming. It's usually done in institutions, and more work needs to be done in this area. We also recommended defining significant maternal morbidity and near misses, something that would be easy for the 3,200 approximate hospitals that deliver babies in our country. And we recommended that to define it, it would include two things: the transfusion of 4 units of Pax cells or greater, or admission to an ICU. Now, there's certainly more sophisticated definitions of maternal morbidity that has been done by Dr. Geller, who will be presenting today. But we felt this was a reasonable approach for hospitals that had low volume. And then with respect to research on the impact of adverse pregnancy outcomes on long-term health, Dr. Reddy, my future colleague, commented on the New Mom to Be study that partnered with NHLBI. So some progress had been made in these 3 areas. If I could have the next slide. Can't seem to advance them here. Now, many talks already today have alluded to the MFM research network. And of the 7 critical gaps that we identified in 2013, NICHD has supported work to address each one of them. And in 2017, a maternal health category was added to NH-wide reporting. And also maternal morbidity and mortality category was added in 2019. And this allows tracking across the system of how much research support is given to these efforts. Since 2013, maternally focused NICHD research has increased significantly. And we were very, very happy to see that, and has led to many important trials that have been previously alluded to. And in addition to the specific research initiative grants and the MFMU, NICHD also supports the Global Network for Women's and Children's Health, the Consortium on Safe Labor, New Mom to Be, that were all pointed out in Dr. Reddy's talk. To simplify data with the research community, NICHD has developed and launched the Data and Specimen Hub, or DASH. It's a centralized resource for researchers to store and access data from NICHD-funded research studies to use for secondary analysis. And NICHD also supports the Biospecimens Repository Access and Data Sharing, or BRADS, a repository of epidemiologic studies and clinical trials. Could I have the next slide? Thank you. We were delighted to see the NICHD strategic plan in 2020, and many of us were involved in the preparation for this, but really it involved 4 areas in Team 3 to characterize the pre-pregnancy and pregnancy factors that can adversely affect risk, to evaluate big data that can inform prevention efforts and address health disparities, to think about define and develop targeted strategies to improve prevention and response to labor and delivery complications that lead to maternal morbidity and mortality. And finally, of course, the impact of pregnancy outcomes on long-term maternal health. So in thinking about where we go next, if I could have the next slide. I think we need to identify our priorities, and going back to the recommendations we made in 2013, I think those 7 are still valid and need to be expanded upon. Surveillance data was highlighted in 2013, and it's still a gap today, but we have made some progress, as I shared with you. During the pandemic, we saw the power of rapid aggregation of data. We saw the speed of publishing during the pandemic and the resources that were brought to bear. And because of that, we're in a better place because of this focus and collaboration, although certainly the lack of pregnant people in clinical trials has been highlighted by many of the speakers today. Maternal health research needs a similar focus. Most of our hospitals use Epic or Cerner as the electronic medical records, And our specialty organizations have clinical informatic committees that are working with these organizations to optimize the contents, the transparency of the clinical data, and the usage. Cynthia pointed out the variability in clinical nomenclature that is used even within a single institution. With respect to the optimal timing for delivery with different clinical conditions, that is what we all strive for. When is the best time and how should we deliver a woman with a clinical risk? We are all aware of the ARRIVE trial, which showed that in low-risk women, nulliparous women, induction was not associated with any increase in cesarean delivery. There was no negative impact to babies, and there was no increase in, and we saw a reduction in maternal morbidity as an additional finding, to me was unexpected. And the ARRIVE trial also followed up with a cost-effectiveness study, which showed a 39-week induction was cost neutral. So where we can identify care models like this ARRIVE trial that improve outcomes and keep costs the same, or ideally bring them down, this allows us to move the needle and divert resources to other areas in women's health. Now, thinking about expanding, if I could have the next slide, thinking about the effectiveness of the various approaches to improve training, I see three important areas that need more research. Some research has been done to show the reduction in maternal mortality with safety bundle implementation. But I believe we really need to know more about optimal implementation for all of the various bundles we have now. We've added maternal sepsis and more recently the cardiac bundle, and how to sustain the principles of the various bundles in various hospital settings, especially low resource settings, and how important and if the bundles are used optimally, what is the effect on maternal morbidity that needs much more work? With respect to simulation, given that maternal deaths occur rarely and life-threatening maternal conditions are of low prevalence, simulation and case-based learning has become the standard in most of our educational programs and is now used by ABOG to evaluate clinicians for board certification. But we need to think as what is the role of simulation? It is expensive. The simulation models are expensive. The amount of time our care providers have in simulation and spending time doing simulation is significant. How much simulation is enough? What types of simulation are enough? And what is the minimum that would be required in a low resource hospital to be effective? And finally, there has been not much on innovation in intrapartum for treatment of hemorrhage or for any of the conditions that we see in the intrapartum period. I was recently privileged to work with industry to evaluate JADA, which is a device to stop postpartum hemorrhage. We published last year in the Green Journal on its initial safety and effectiveness leading to FDA approval. This could be potentially of significant use in low resource settings where there may not be the immediate availability of massive transfusion protocols or any blood in significant under-resourced settings. Next slide. And then, of course, as has been said by so many, and Dr. Janet Rich Edwards in the previous talk, expanding the research beyond our hospital walls. We know that maternal risk is intrapartum is not always identifiable, but many times it is. And our neonatal colleagues have really led the way in terms of levels of care for neonatal units. And the usual scenario in OB is, you transfer the mother to an appropriate setting where it's best for her baby. ACOG has long had an organizational priority to the levels of maternal care. And this was published by ACOG. The levels of maternal care were published by ACOG and SMFM in 2015. And more recently, ACOG announced a partnership with the Joint Commission, and they will use their combined reach across the country with practitioners and with healthcare organizations, state health departments, and many programs to implement levels of maternal care more quickly. This will give us an ability also, as we evaluate maternal levels of care, to evaluate the impact on maternal outcomes. When I think about risk, I think about what is the optimal time to refer a patient. And because sometimes for patients living in a rural environment to come to a city, it's very difficult on the family. And often we don't know the optimal time for referral. More work needs to be done here. And when I think about prediction of risk for maternal mortality and severe maternal morbidity, I go back to my earlier things about my earlier paper on comparing what we have done in fetal and neonatal medicine and what we have not done in maternal risk. For instance, if I'm in front of a pregnant mother, I can tell her what her individual risk for carrying a baby with Down syndrome or another trisomy. If she's admitted at 23 weeks, I can give her a very clear idea of what will happen with her baby if it's born at 23 weeks. With respect to maternal risk, I don't have anything to give, anything close to that same level of prediction. And I think we really need to look at all of the issues that have been discussed today in terms of evaluation of risk, not just our clinical diagnosis, such as age, hypertension, diabetes, mental health, but the exposure to racism, food instability, housing instability, the reduced access to care. We've got to broaden our study of drivers of serious maternal morbidity and mortality to include the social determinants of health, especially in the years before pregnancy, as Dr. Janet Rich Edwards has been telling us for so long. So which brings me to my final call for more population-based observational control studies, thinking all of the parameters that were identified by both Uma and Cynthia in their presentations today. So next slide. In summary, I think that the continued relevance of the 2013 recommendations for me is both reassuring and also a cause for pause. Reassuring because I think we were on the right page and we've made some progress for certain, but a cause for pause because, as has been identified by everybody, there's a lot more work to be done. I think it can still continue to be a solid framework, and we need to identify new opportunities, especially with leveraging data nationally, as well as the development of new technologies and partnering with industry. When I started this work, I became involved late, probably in 2010. My main concern was trying to raise awareness. Thanks to the efforts of so many, this has happened. But this has happened, I think, predominantly not because of the work of clinicians, but the work of the media with ProPublica, which really did move mountains in increasing risk and increasing awareness of risk. And the powerful stories of the families that were alluded to in Liz Howell's talk. It's well known now that we have a crisis and there are unacceptable racial disparities involved. Our research focus, in my view, must focus on solutions and how effective our solutions here are, the bundles and simulations, and how much these solutions are addressing the gaps that we continue to see. And finally, as I always say to my own team, no one doctor can take care of a complex pregnant patient. I've heard Marianne Atiabet from Merck for Mothers describe so well maternal mortality and morbidity as multifactorial and multisectorial. We need research at all levels of care and societal influences that affect maternal health to drive down disparities, medical, public health, community. We all need to work together and collaborate on research to get the full picture and make further improvement. I really believe, and I'm optimistic, that the talent and the organizational capacity in our field, we can anticipate great results over the next decade in this endeavor that will not only improve the lives of mothers in our own country, but around the world. Thank you very much, Yoel.